I'm very happy to introduce now Adrian Saftoiu, the past president of EFSUMB, and he has already performed studies on artificial intelligence in gastroenterology and in special this endoscopic ultrasound, I think 10 years ago or more than 10 years ago, and now has published a very important study which now summarize all these techniques of multiparametric ultrasound and combines this with artificial intelligence. And I'm very happy to announce his lecture on artificial intelligence in gastroenterology and in special in its clinical application for pancreatic disease. Please, Adrian.
Thank you very much, Christian, for the very kind introduction. So I will try to cover the applications of artificial intelligence, of course, with emphasis on ultrasound and endoscopic ultrasound. Basically, when talking about artificial intelligence, this is an overlapping term with machine learning and deep learning. Recently, we have heard this term of deep learning. Basically, this is a software that performs brain functions, and it's a combination of computer science and statistics because it has repeated iterations which improve performance over time. So the more data we feed into the software, then the better it gets. And of course, everybody has seen already applications in, for example, in driving, in automated cars which drive by themselves and recognize other cars, but also in all sort of applications that we use all the time, like Google Translate, for example. So a lot of artificial intelligence techniques are already embedded in the devices that we are using all the time. And this will, of course, happen in endoscopy and ultrasound. And we will see more and more clinical applications. What is the definition of artificial? They are supervised machine learning models. They are inspired by the neuroanatomy of brain. So basically there is an input layer, and then there is an output layer. And in between them, there are hidden layers of neurons, so-called neurons. And each of these neurons has some interneuron connections with other neurons. And these interneuron connections are weighted according to the training set that we are using. So if we use for the input layer several categories of images, and if we know the diagnosis for each individual image, then we obtain at the output layer the diagnosis. And usually there is a training set, and then after the neural network is trained, then we are using a testing set to calculate the accuracy of the particular neural network. Of course, there are applications in gastrointestinal endoscopy, and I don't want to talk about this too much, but there are clinical applications already in the market, and this is important for us as gastroenterologists. Artificial intelligence has been used already for detection, including polyps and bleeding, because it improves the detection accuracy. It has been used for diagnosis for early cancer, for staging as well, both for polyps and again, advanced cancer and IBD. And it has been used for therapy for lesion delineation and risk stratification, and for the choice of therapy plan. And this is an example from the literature of computer-assisted diagnosis. There are applications already for esophageal adenocarcinoma, for squamous adenocarcinoma, and also for gastric adenocarcinoma. And this is an example of an early gastric adenocarcinoma, where an artificial neural network reaches a sensitivity and specificity of over 95%. And this is one of the systems that it is in clinical use already. It's available on the market. So it's a system for computer-assisted detection automatic detection of polyps. And you see that over 95% of polyps can be detected with 60% false positives. However, it's very important because it increases the accuracy in both white light, narrowband imaging, and also other techniques like eye scan or blue laser imaging. So for polyp characterization, there are applications already. This one is on the market in Japan. It's a system called EndoBrain, which uses endocytoscopy, and it helps the differentiation of neoplastic and hyperplastic polyps. Then we have used this kind of technology for inflammatory bowel disease. This is an example of computer-assisted diagnosis, again with endomicroscopy, and we have used as an input normal images, confocal laser endomicroscopy images, and images with inflammation. And when we trained the neural network, this was the structure of the neural network, and as an output, we had normal and inflammation categories. So the system automatically makes the diagnosis when an image is fed to the system, then it automatically classifies the image as normal or inflamed. And in this way, it can be used with endomicroscopy. And one interesting application is, again, capsule endoscopy. Capsule endoscopy, of course, provides a lot of images. And in this way, an artificial intelligence module can help us detect the bleeding source automatically. So the doctor doesn't have to spend 4 or 6 hours looking at a capsule endoscopy movie. Then moving to ultrasound, then there are various applications already. If you look at the literature, there are various applications reported for detection and characterization, for example, in focal liver masses, including CEUS, contrast enhanced ultrasound, but there are applications also for breast, thyroid, prostate, and pancreas. And there are applications also for staging, for example, of hepatocellular carcinoma, and therapy for lesion delineation, risk stratification, and therapy planning. Basically, when looking at focal liver lesions, this is one of the studies in the literature. You can see that the detection rate of automatic detection rate is over 93%, and the differentiation is over 90%. And if you look at one of the studies published last year, this was superior to radiologists and comparable to CT. It was a bit lower than MR imaging. There are also applications for hepatostatosis. This is one of the application. You see that, again, the accuracy, the area under the receiver operating curve is higher than 97%. It's clearly higher than the hepatorenal index, and it's higher than gray level co-occurrence matrix algorithm, and it can automatically detect liver statosis in images. Then for breast, there are applications, and you can see there can be an automatic segmentation, so automatic detection of the boundary of the nodule. This was one of the studies which reported an 80% detection rate with various open access options on the market, including GoogleNet, Inception, and ResNet, and VGG. These are all types of convolutional neural networks which are in the open access domain and can be used for medical imaging interpretation. Basically, for thyroid, again, this is another study which used segmentation, and then you can see that the precision was over 90%, and you can see that the area under the receiver operating curve was over 95%. Moving to the pancreas, this is again an example from the literature, is one of the few studies which are published, and this is an example of deep learning pancreas segmentation and station recognition. So it's a an automatic system used for training, which uses both the endoscopic image and also the EUS image. And you can see how a convolutional neural network can detect the normal pancreas and also the vascular areas. This is the aorta and celiac trunk. And you can see that the system is pretty good in recognizing, again, aorta and celiac trunk, but also the normal pancreas in this image. And in this way, several stations can be targeted. And in this way, the operator can be confident that he covered all the stations that we need for endoscopic ultrasound. Endoscopic ultrasound has a long learning curve, and this kind of convolutional neural network can help the operator to choose and mark the individual stations. Now you see another station near the kidney, so it's a pancreatic body and tail, and now the endoscope is inserted deep in the second duodenum, and you will see in this station the uncinate process of the pancreas. So you can see it here, and actually the ventral and dorsal part of the pancreas. So this was one example, and of course it can be used also for focal pancreatic masses. And initially, when we started working with neural networks some years ago, we looked at elastography and we tried to differentiate chronic pancreatitis and pancreatic cancer. And we had a 94% differentiation rate using an artificial neural network, which was higher than histogram analysis. So actually, a neural network performed better than the simple histogram analysis. Then we looked at the pancreas with the same technology. When we looked at quantitative EUS, we used an artificial neural network, and this was the structure, the type of artificial neural network that we have used, and we have as input, we have inserted several parameters of the time intensity curve, including peak enhancement and then area under the curve and other parameters. And then as output, we have tried to categorize patients with chronic pancreatitis and pancreatic cancer. And actually the sensitivity was really high, higher than 97%, with a specificity of around 90%. And then just to briefly cover what Christian mentioned, that we have published our results this year in PLOS journal, which is an open access journal. And we have tried to use this kind of technology for real-time differential diagnosis of focal pancreatic masses. We have used convolutional neural networks, and we have used multiparametric endoscopic ultrasound. We have used both grayscale, color Doppler, contrast enhancement, and elastography to try to differentiate automatically various lesions. We have worked with a group in the technical university, and basically we have used images, again, grayscale, contrast enhanced, color Doppler, and real-time elastography. And we have inserted this kind of images into a convolutional neural network. Basically, we had used 5 images from each technique from 65 patients. And then for the final diagnosis for the output, we had 3 categories: chronic tumoral pancreatitis, pancreatic neuroendocrine tumors, and pancreatic ductal adenocarcinoma. Basically, we have used one of the EUS system on the market for all this thing. And for each patient, this is an example of chronic pancreatitis. So this is the grayscale image, which reported a hypoechoic mass. The elastography showed a mixed pattern. And then the color Doppler showed hyper enhancement, and contrast in the arterial phase and venous phase were also hyper enhanced. Then for patients with neuroendocrine tumors, again, in grayscale, the lesion was hypoechoic, but it was stiff on elastography. And then the lesion was hyper enhanced in the arterial phase, and it washed out in the venous phase. And in color Doppler, it was again hyper enhanced. For the patient with patients with pancreatic adenocarcinoma, the lesions were hypo-enhanced in grayscale. They were stiff in elastography. Then they were hypo-enhanced in both the arterial phase and venous phase of the contrast, and hypo-enhanced as well in color Doppler after contrast injection. And we used all these images in a convolutional neural network with a long short-term memory network. And this kind of component has been used for dynamic analysis of the contrast examinations, which were dynamic. And basically, then we used a concatenation layer. So this was the structure of the neural network. Actually, for each type of images, we have used a separate neural network and then a concatenation layer, which combined all the information. And after this, we had 3 categories again: adenocarcinoma, neuroendocrine tumor, and chronic pseudotumoral pancreatitis. And we have used this kind of technology for training and testing. So basically, for training, we had used 13,000 images. For validation and testing, 325. So in total, 1,625 individual images. And then we run the fast computer, we run the software, and we used Keras with Google TensorFlow to implement the convolutional neural network in this study. And then the algorithm was trained iteratively. And you see that after the first 150 epochs, we already reached an accuracy of 96%. So this was the ideal situation was somewhere in between 120 and 140 iterations. And the next step would be to convert this kind of software into a real-time software, which can categorize the individual images in real time. Of course, this is work in progress, but we will probably see this kind of imaging systems in place for both ultrasound and endoscopic ultrasound as well. Thank you very much.
Thank you very much, Adrian. I see 2 questions in the chat. Yes. Boris Tarashuk asked you what you could tell about difference in vascularization. Both of them have, no, this is related, I think, to the last lecture with regard to the serous cystic adenoma and neuroendocrine tumor. But a question which is related to artificial intelligence is how affordable is artificial intelligence? It is yet to be used in the developing countries. And I may add, it is already clinical practice in developed countries.
Yes, well, of course, the clinical applications which are on the market are quite expensive. But I think they will get cheaper and cheaper because most of the software is open access. So usually the software used for artificial intelligence is open access. So I think each group will develop their own clinical application in artificial intelligence. So for the moment, of course, they are really expensive, but I think they will get cheaper in a few years. It's a normal evolution for software applications, but they have to reach a point where the accuracy is high enough to be used in clinical applications.
Okay, are there further questions? We can come back to the question of Boris Tarashuk on differences in vascularization of neuroendocrine tumor and serous cyst adenoma. Adrian, would you like to answer this question? And is there any difference in shear wave elastography between neuroendocrine tumor and serous cyst adenoma?
Yeah, it's difficult because it's the number of studies it's quite limited. But if you look at the serous cyst adenoma, I think you can tell that it's a serous cyst adenoma when looking at the grayscale image. because you see sometimes most of the cysts are really small, but sometimes there are a few cysts which are a bit bigger. So I think it's different, and all the cysts are really filling all the space. So it's a bit different than a neuroendocrine tumor. And concerning the vascularity, there might be differences, especially in time intensity curve analysis. But again, there are not too many studies. So I think fine needle aspiration will clarify this in most of the cases. Again, when using a neural network, for example, in this case, then for sure it will pick up the differences and it will differentiate the two, even though they look more or less the same in grayscale or even in contrast enhancement. So I think when you look at a lot of images, you will be able to see a serocystadenoma immediately, I would say. But of course, it takes some experience and time.
This could be also a question to artificial intelligence, I think, to train the artificial neural network with the various types of serous cystadenoma and neuroendocrine tumors. And of course, there are a lot of different morphological types of both diagnoses.
Yeah, I agree. And with artificial intelligence, I think it will develop. One of the problems is the number of images. So the more images are used for the input, the better the neural network becomes. So I think that in the future, if several groups will interconnect, I think they will be able to provide a large library of images which can be used for training. So I think it will progress for sure in the future.
Adrian, could you please comment what's the difference to use video files compared to still images with artificial intelligence? Did you use only still images or did you use also video files?
For the initial training, we have used individual images, but this can be combined in a computer software because actually the convolutional neural network looks at each individual image in a video file, and you need a good computer, not a supercomputer, but a pretty fast computer, and it will actually, when you will run the software, it's the same thing with the polyps. So when the video image runs, then the neural network interprets each frame very fast. So it can categorize actually each frame. And then it will reach an accuracy which can be displayed. But basically the training and the testing phase are done in still images. That's how we have worked until now. And then there is a software which analyzes the real-time video ultrasound movie, but actually it analyzes each individual frame in the movie.
Okay, thank you very much, Adrian. I think this last lecture was very interesting and really a glimpse into the future, which was the name of our webinar. And I hope you had some new information, and we can now close our session and have a good time. And let's meet at least in Timișoara next year at the WFUMB and Eurozone Congress. Goodbye.
Goodbye. Thank you very much.